In this Medicoapps masterclass, we are going to learn about chronic tubulointerstitial disease. Interestingly, these chronic tubulointerstitial disease are also referred to as ciliopathies. Why? Because there is a defect in the cilia of the kidney. So the next question comes, where are these cilia found? So they are found in the proximal convoluted tubule, they are found in the distal convoluted tubule, and they are found in the collecting ducts. Very importantly, all these cilia are non-motile cilia. What is the function of non-motile cilia in these kidneys? So remember, these non-motile cilia acts as sensors. They sense level of different electrolytes in the urine to be formed, and based on their sensing, electrolytes are either excreted back or reabsorbed. Okay, where is motile cilia found? So motile cilia found is in lung, and it's very important for embryonic development, and we saw that if there is a defect of that, we will have Carter-Neger syndrome. Very important MCQ, we have learned it in much detail. Another very frequently asked question they will ask you is, in which part of the body non-motile cilia apart from kidney is found? So remember, retinal pigmentary epithelium is where they will be found. Okay, so even in retinal pigmentary epithelium, there is non-motile cilia. So what are these ciliopathies? So we have 5 specific ciliopathies which we are going to study. Number 1 is adult autosomal dominant polycystic kidney disease, also called as adult polycystic kidney disease. Then we have got autosomal recessive polycystic kidney disease. We have got medullary sponge kidney. We have got autosomal dominant tubulointerstitial kidney disease, also called as medullary cystic kidney disease. And the last one is nephronophthosis. Okay, so these are the 5 ciliopathies which we are going to learn in detail. So before I take you to individually each one of these in detail, let me show you some clinical images of the gross pathology, because this has been asked in the examination. So what you can see in this particular image, literally your kidney is studded with cyst, and this is what you see in autosomal dominant polycystic kidney disease. Let's look at the next diagram. So what you can see here is striations, okay, and this is what you see is in your autosomal recessive polycystic kidney disease. What do you see here? So here you can see there is cyst at the junction of the cortex and the medulla, and this is what you see in medullary cystic disease. Okay, next you can see here very small multiple cyst. Okay, and this is in renal medulla, multiple cyst in the renal medulla, multiple small cyst. Okay, and this is what you see is in medullary sponge disease, renal medulla, medullary sponge disease. So all these gross specimens are very important because they have been asked in the examination. So let's look at a diagrammatic representation so that gets into your brain. A single isolated cyst, it's called as a simple cyst. Kidney which is studded with cyst, we have seen it is autosomal dominant polycystic kidney disease, also called as adult polycystic kidney disease. If you have striations like this, radial striations, you see it in autosomal recessive polycystic kidney disease. If you have it at the corticomedullary junction, then you call it as a medullary sponge disease, and if you have it in the medulla, you will have medullary cystic disease. So all these are very important, and essentially we will look at each one of them one by one, their pathogenesis and their clinical features, and how do we investigate, and what are the investigative findings which you see in each one of them. Now let's look at medullary sponge kidney disease. Now medullary sponge kidney disease, basically it's sporadic, and there is a developmental malformation of cilia, because of which there is a cystic dilatation of the collecting ducts. It's generally an incidental diagnosis at the age of 50 to 60. So what are the clinical features which you will find when you take a history? So one of the most critical clinical feature will be renal stones. So these patients will have very frequent formation of renal stones because of there is a defect in the collecting ducts, and these stones most commonly are calcium oxalate stones, and because of this you can have also history of renal UTI, pyelonephritis, tenderness at costovertebral junction. You can, because these stones can be jagged, so you can have hematuria. Okay, there can also be polyuria, because again the collecting ducts are involved. You can have, because peritubular cells are also affected and they will be decreased in the production of erythropoietin, therefore anemia can also be seen in these cases. If the distal convoluted tubule is also affected, you can have renal type 1 acidosis. So this is it, the most common and the important clinical feature which they will give you in the question is recurrent stones of calcium oxalate. Okay, if you do investigation, so if you do an IVP, you will get a paint brush appearance or a bucket of flour or papillary blush. So these are important, so you can see the paint brush appearance. Now IVP we generally not do, we do a CT scan, and on CT scan you can see papillary calcification. Okay, you can see papillary calcification, and as this image shows, if you do a gross, so you can see the medulla has very small cyst, very small cyst in medulla. So this is your medullary sponge kidney disease. In this part of the lecture, let's look at autosomal recessive polycystic kidney disease. Now we know that in autosomal recessive polycystic kidney disease, we have PKHD1 gene affected, which is on chromosome 1, and the protein affected is fibrocystin and polydactin. Okay, and it primarily affects both distal collecting duct cyst. Okay, and if you see the gross, as I have already shown you, there will be radial striations, radial striations. Now they are diagnosed generally early, can be diagnosed as early as 24 weeks of gestation, and when you do an antenatal ultrasonography, you can have large kidney with loss of corticomedullary differentiation. There can also be oligohydramnios because there is a kidney malfunction. There can also be pulmonary hypoplasia, and this is one of the most important causes of death in a neonate. And these children will not only have renomegaly, but they will also have hypertension, and they will reach an end stage renal disease in these patients. And this again is very important cause of death beyond 1 year of age. So once you have seen it, very importantly, frequently they will ask you is the extra renal manifestation of autosomal recessive kidney disease. Okay, and the first one is congenital hepatic periportal fibrosis, and this will lead to a lot of symptoms which we see in portal hypertension, like esophageal varices, hematemesis. So very young child having hepatoportal tension, and they will be having esophageal varices and hematemesis. Second important extrarenal manifestation will be biliary dysgenesis, and you will have Caroli's cyst, that is type 5 choledochal cyst. So these are very important extrarenal manifestation. Similarly, very important, just I mentioned, extrarenal manifestation of adult autosomal dominant polycystic kidney disease. So remember, you will have hepatic cysts. Okay, you will have pancreatic cysts as extrarenal manifestation. You can even have splenic cyst. Okay, you can have belly aneurysms. Okay, and lastly you can have colonic diverticulosis. Okay, so these are the important extrarenal manifestations of adult polycystic kidney disease, also called as autosomal dominant polycystic kidney disease. One frequently asked question will be, which organ, in fact all the organs can have cysts in adult autosomal dominant polycystic kidney disease, which organ generally is spared or the cyst is not seen? So remember, it is the lungs where cyst is not seen in autosomal dominant polycystic kidney disease. Very frequently, all of these are very important MCQ point. How do we work up? So we know that we can do an ultrasound or CT scan, and you will find a kidney with loss of corticomedullary differentiation. How do we manage it? Primarily symptomatic. So for hypertension, we will give ACE inhibitors, and because potassium may be increased, so we can give Partomers or SPS resins, and the only treatment which is available is allogenic kidney transplantation, because allogenic kidney will not have that gene, and the patient will be able to survive. So allogenic kidney transplantation is the treatment or management of choice. Okay, in next part let's learn about autosomal dominant tubulointerstitial kidney disease. So these are also now called as medullary cystic kidney disease. Okay, earlier it was called as medullary cystic kidney disease. Now the latest nomenclature is autosomal dominant tubulointerstitial kidney disease. Now what are the genes which are defective? So one we have got is MCKD gene 1. So here the MUKID 1 protein is affected, and then MCKD gene 2, where UMOD, that is uromodulin, is affected. Uromodulin also we know by the name of PAM horsefall protein. Now this is the adult version. The juvenile version or child version is also called as nephronophthisis. So the basic pathophysiology remains the same. Only thing is the genes which are affected are different. So what are the genes which are affected? So NPHP1 gene, which is found on chromosome 1, and NPHP2 gene, which is found on the chromosome 9. And what is the basic pathogenesis in all these diseases, that is autosomal dominant tubulointerstitial kidney disease and nephronophthosis, is that all these proteins are synthesized by ascending limb of loop of Henle, and then they are excreted in form of cast, that is haline casts. Okay, in these conditions these are not excreted, and they get accumulated into tubulointerstitial disease, and therefore this the damage to these cells are there, and they are not able to form function properly. So very importantly, you will have absence of casts in urine examination of these patients. So there will not be any hyaline cast, epithelial cast, RBC cast seen in patients of tubulointerstitial kidney disease. Okay, now features which are common to both juvenile as well as adult presentation is salt wasting, polyuria, anemia, failure to thrive, stunting. Feature which is not seen is basically casts and dysmorphic RBCs. RBC, remember, hematuria is primarily a feature of your glomerular disease, because glomeruli is normal, so you will not have hematuria, so you will not, and because casts are not formed, so you will not have casts in these patients. One feature which is very specific to your adult presentation is increase in the uric acid level. And what are juvenile presentation is generally associated with your Joubert syndrome, and here there is an agenesis or hypoplasia of vermis of cerebellum. There are two very important radiological findings. One is called as the molar tooth appearance. So you can see, there is a look of a molar tooth, also called as another very peculiar feature, radiological feature on CT head you can find is bat wing appearance. So if you see here, this portion looks like a bat wing, and both is primarily due to the agenesis of vermis in cerebellum. So adult dominant polycystic kidney disease, we have a complete different lecture, but in this lecture I have tried to cover all the important ciliopathies in whatever detail it is generally asked in the examination. Hello students, thank you so much for clicking to watch the explanation of this video. I'll take some 10-15 seconds to give a very important announcement. I've just published a book which has NEET PG 2018 to 2023, all the questions, and this book was much requested by all of you for a very long time, so I've just finished it. It is available both on Amazon as well as it is available on Medicoapps store. Now, one additional benefit I can offer you if you buy it from Medicoapps store is that not only you will get the book, but you know that we have a NEET PG previous year QBank in app form. Okay, and in app form the question papers are from 2012 to 2023, so almost 11-12 years question paper is there. In the printed form it is 2018 to 2023. So if you order it from our Medicoapps store, the link is there in the description, you will get the app, full year access with all the question bank 2012 to 2023 as well as the book. So please do go buy it from Amazon, and if you're buying from Amazon, please leave a review. And if you want to buy it from Play Store, from our Medicoapps App Store, then you can just click on the link and you will find a description of that particular book.